So thank you everybody for my invitation here to Madrid to this very engaged meeting, I have to say. So I want to report about our findings concerning the arthroscopic technique of autologous chondrocyte transplantation using Condroesferas. This is a precursor study, if you want. So it's not evidence-based data, but it's a look into the pipeline, what will come. So first of all, Condroesferas, what is it? So it's a tissue-engineered, strictly autologous chondrocyte graft without non-autologous matrix. This means there is no foreign matrix in the graft. It's only the matrix synthesized by the chondrocyte itself. It's grown in the patient's own serum and covered with antibiotics. So the spheroid formation is induced by the synthesis of special cartilage-own matrix and three-dimensional cell-to-cell contacts, so that you get little balls containing about 200,000 cells per spheroid. And it's a diameter of 1 to 2 millimeters. So it's the ideal carrier for an arthroscopic procedure. So the adhesion of the spheroid to the bony plate is induced or is done by a so-called focal adhesions. So these are transmembrane proteins like integrins, ICAMs, or fibronectin. So you don't need external fixation materials like fibrin glue or sutures. The spheroids were introduced in the clinical use 2002 as an open procedure, and the aim of our study was to prove the safety of an arthroscopical procedure implanting the spheroids. So we published this 2007. And for that, it was the starting point for our study. So we included 42 patients with full thickness cartilage defects in the knees with a clinical follow-up of 2 years. The MRI follow-up was done by an independent inter-observer radiologist, not being part of one of the centers. The mean age was 42 years with a mean defect size of 4.7 centimeters square, ranging from 2.5 to 9.5 centimeters square. The clinical assessment was done by Lisson score, WAMEC, Taken Activity Scale, and the MOCAD MRI scoring for repaired tissue. The exclusion criteria regarding the guidelines of the German Association for ACT, and the majority of defects was located in the medial compartment with 55%, 40% in the lateral compartment, 70% in the trochlea, and 10% in the retrocapsular compartment. We implanted mean 38.5 spheroids per centimeter square, corresponding to 7.7 million cells per centimeter square. This means the threshold dose of 1 million cells per centimeter square in the classical ACT was not underrun. So for the arthroscopical procedure, you have to create, after debridement of the defect, a dry working space. This means that you have a good handling of fluid. So you will pose a suction cannula at the base of the joint line with a moderate suction, and then you are dropping the spheroids into the in the defect, and then you do the dispersal with the probe, and then the adhesion time for the spheroid is 20 minutes, what is the most hardest moment in ACT transplantation. to be in the OR and doing nothing than to wait. So there you see you have dropped your spheroids to the bony plate, and then you do the dispersal, and a sign that the adhesion is done is when they're loose, their round formation are going, that are flattening a little bit. So we do that also in the retropatellar and trochlear compartment, and I think it's the most thankful area, because when you're going for an open procedure in the retropatellar compartment, this means that you have to invert the patella. This means big soft tissue damage with scar formation, with drives, with problems in the suprapatellar pouch. So in the arthroscopic application, we can surely diminish the soft tissue damage. For the retropatellar access, you can use the hammer technique by my former chief and friend Hans Kessler, when he is pulling two sutures through the quadriceps tendon, and he hang up a hammer to pull the patella downwards, and then you do the arthroscopic procedure in the prone position. Me, I prefer to stay in the standard arthroscopic setting, and the key for this technique is that you have an edge where the fluid can go over the edge and the solids are resting in the defect. It's a kind of gold digging technique, yeah, where you want to save your nuggets. Okay. So here you see in standard arthroscopic position the debridement of an osteochondral lesion after dashboard injury. Here you see the drying of the defect, and then you go in with this system. And what is new? I thought I have only 10 minutes for presentation, so I cut off this part. We have a new specific catheter system. What is on the first time a guide who is transparent, that you can see the Condroesferas and that you can move through the capsula. And then you have the spheres in the special guide wire system. This means you can use a pigtail technique like in the urology, that you can give a direction. And if you go out of the tip, you can turn 360 degree and you can go on top. That's the reason why we can do this operation in standard arthroscopic setting. So for the results, in the clinical assessment we had a significant improvement in the Nussbaum score from 47 points to 79 points. Also in the Tigner activity scale, increasing activity from 2.5 to 4.3. The WOMAC showed significant decrease from 4.1 to 1.4, with a significant decrease also in the subgroup pain, stiffness, and function. So these are the MRIs 1 year from the guy with the osteochondral lesion. I showed you that because I also wanted to see how much we can fill up. Where is the frontier, what we can fill up? So the depth of the osteochondral part was 5 millimeters. So what you see is here that we have in the sagittal plane a good filling, but here you have a slight bump. But you see a good filling from the baseline, and in the clinical assessment it was one of the best. So what we were seeing in the MRI assessment by Trutnik a good filling defect with 70% of complete filling, 10% hypertrophy. Sounds terrible, because we're all thinking on the periostal hypertrophy from the periostal coverage, but it means that the filling is a little like a slight bump, if you want. It's not the enormous hypertrophy, from the periostal flaps. So, what is a good marker too is the integration to the border zone with a 5% of complete bonding in the MRI. So, what can we say after 2 years? Is that we had no major loss of spheroids. This parameter was hard to screen because you can't count the spheroids afterwards. We tried to count it on the pictures done by in the ORR, but we had to estimate the intraoperative loss by the surgeon. So the critical size for us was that we lose so much spheroids that we underrun the 1 million threshold dose of classical ACT. And in the estimations, we were underneath 10%. This means losing 5 spheroids. We had no revisions in the 2 years follow-up time. We had no intraoperative conversion to an open procedure, and we had no infection. As complication, we regarded one thrombolysis. So we have some second look arthroscopies. This will be part of our second step of study, where we had at the 2 years endpoint we will have a second look arthroscopy with biopsy, but we don't have the data yet. But in the second looks, we had a good homogeneous filling of the defects. And then this is important to get the confidence in this type of graft, because when you are leaving, you leave the defect with little yellow balls on it. With a matrix, you can say, darling, it was right in the OR, I closed the defect. So it's giving a good feeling to the surgeon, but it's not a biological approach. So we have to learn and to be confident in the biologic repair. So it's minimally invasive. We can reduce massively the soft tissue damage. It's full arthroscopical. It's for a well-trained arthroscopic surgeon. No additional time loss, and we need for a transplantation in being 55 minutes now. Further application like tails, shoulder, or hip are possible, but we have to emphasize that today we have no prospective control data versus gold standard like microfracturing, MACI, or AIMI. But this is the work to be done in the future, and I hope in future that the saying only steel can heal is left, and that we are going to a biologic law. Thank you.
Muchas gracias, doctor Rossing. Doctor Rossing también tiene que organizar su partida. Doctor Rossing, puede que haya alguna pregunta en la sala para usted. Empezamos por nuestro grupo de expertos. ¿Hay alguna cuestión?
Sí, en primer lugar felicitarle porque parece algo muy novedoso y esperanzador y evidentemente necesitamos tiempo para saber resultados. Pero yo solo me ha quedado una duda. Lo que rellena el defecto, ¿qué es? ¿Qué tejido es? ¿Es tejido conectivo? ¿Es tejido celular? ¿Es matriz? ¿Es fibrocartílago?
So this is a good question that we can't answer without a good histologic study. That's what we don't have actually. Sorry. Okay, I try it again. So it's a very good question because we don't have histological data. From the second look, arthroscopy is a good and firm, consistent. I don't think that we have full hyaline cartilage. I think it's at the time it's not to believe that any graft can restore complete the histologic quality. But what is important for me is the mechanical behavior. Is it stable? And that's also for me the key versus the microfracturing technique, because when we treat the big defects and we go back to the joints, we see often that there is a scar formation who is not really stable. So at first time for me is this firm and stable cartilage-like formation, yeah, who will restore as good as possible the function. Another step is, I think, there is a good study done by Dr. Richter from Heidelberg, from the orthopedic department, who looked to the different grafts. And when we get the graft back from the laboratory, they say, yeah, they are living cells. But she looked a little bit nearer, and we had in 60%, we had apoptotic changes in the cells. So they live, but they were assigned to dead. And I think that this is a problem still in the labs from the quality of cells we can get from the lab. So at the moment, the only possibility is to solve this problem by the amount. So when you have 1 million cells in the graft and 60% are already signed to dead, you underrun the threshold dose. So if you put 4 million, you will be safe over. Yeah? And so that's the two things I would regard. And the third thing is what is the advantage that we are leaving the non-autologous matrix. But because we don't know much about the interface of a foreign matrix with the chondrocyte, and why doing in a matrix, a foreign matrix, the body has to remodel, to resolve, to reabsorb. So we are bending the capacity, the biologic capacity to remove the scaffold. And we don't know what is happening to the cells in this interface because the changes are in the system. So I'm not sure when the absorption of the scaffold is done that there is a big differentiation. You're a good cartilage cell, I don't touch you. And on the other side, your scaffold material we have to remove. So I think one of our problem also going to our histological goal to restore real cartilage is in the interaction of a matrix, yeah, with the cells. So a biologic approach is for me that we get a carrier with the body own matrix. So I think the Condroesferas might be a good approach in this biologic pathway.
Doctor García Nablet.
Yo quería hacer la pregunta anterior era para todos los de la mesa, como vamos haciendo en parte se la voy a hacer también a él. Me interesa saber la opinión, digamos, de la industria. ¿Usted considera, es la misma pregunta de la mesa anterior, ¿usted considera que este tratamiento ya tiene una evidencia como para, o por lo menos una práctica como para ofrecerlo fácilmente a nuestros pacientes o si todavía cree que está en una línea investigadora en la que debemos seguir. Una línea investigadora en la que hay que seguir y nuestros pacientes tienen que entrar dentro de algún tipo de estudio para ver hacia dónde va esto.
So it's a clear answer, it's no, because we are not evidence-based at the moment. But when you're starting with a procedure, you will never be evidence-based from the beginning, because you won't start with 10 years follow-ups. That's our problem, but I think it's a good way we should continue, and that this was also the goal of this study, to see what are the problems of an arthroscopical application. What are our problems in this, and is this suitable to get the next step in a comparative study versus a gold standard procedure like microfracturing? And this is what we are doing actually now. In Germany, we have one big group who are doing now the trial in the open procedure, and there is an arthroscopic section who will do that in an arthroscopical setting.
¿Qué beneficios cree usted que vamos a tener con esta técnica respecto a las que manejamos habitualmente? Con el MACI, con las microfracturas o incluso con el Condroesferas que se nos ha presentado.
The advantage is it's minimal invasive, full arthroscopic. And that's what Dr. Schreier from Darmstadt also presented on the ICRS in Sitges, is that we have an early and faster rehabilitation to the open procedure. Overall, he looked to arthroscopic application and open application and the spheres with a periosteal flap. So, and after 2 years, the outcome was the same, but we had an earlier recovery in the arthroscopic group, especially starting to getting significant up to 6 weeks after operation, and that is due to the soft tissue trauma. And I think this is the great benefit. It is still a 2-time procedure. It's still a high-cost procedure, but I think it's for the bigger defects. And you have seen that we started from 2.5 to 9.5 centimeters square. I think we will see a superiority in the further trials regarding to microfracturing, because we have several studies, and Dr. Almquist also said that we can see a superiority from the mechanical behavior. So I think the chondrocyte transplantation will be the domain for the big defects, and I think the advantage of this kind of type is that you have no great problem with the congruency. So you can do it on all parts of the joints, even if they are very curved. This what the problems you have with the OATS procedure or the true fit. So you have a limitation due to the curvation of the joints, and I think this is a big advantage.
¿Hay alguna pregunta en la sala?
Un momento, Paco, no quería comentar que en la comunicación siguiente Primitivo nos va a contar va a contestar más cercano a lo que han preguntado la mesa de expertos, o sea, porque él tiene experiencia clínica aquí cerca en La Paz sobre este tema.
How can you control the growth of the cells in the joint? And well, I have seen procedure, and I think that the pipe or the tube that is very is wide, and when you put the cells in the lesion defect, all the cells go to a certain place, and if you want to put in all the lesion, it's very difficult. Well, I think that.
I don't think it's so difficult. With a new cuff-fix system, it's more easy to get more points in the lesion. But once you have dropped they are on one point, then you only have to disperse it with the probe. It's no problem. It won't adhere to the probe, and you can easily move it and move them over the defect. It's not a problem. What is more the problem, at least at the beginning, is to control the injection of the spheres into the joint. And what is very important, that you cut off the suction, but that you open the scope, that there is pressure equilibration when you're doing the cells in. Because when you have still the suction in, you are seeing fast flying balls. And that's not good for your blood pressure.
And how can you control the growth of the cells inside that?
The question was how we control the growth of the cells in the defect. It's what we did with the MRI. There's a special scoring system from Tratnik regarding repaired tissue.
Bien, pues muchas gracias.